Is it on? So good afternoon. First of all, thank you for staying here. I know it's very, very late and everybody is very tired. But I think this afternoon can be very interesting. So the first debate is functional outcomes need to be used for assessment of treatment effects of drugs for non-neovascular age-related macular degeneration. And the speaker is Michaella Goldstein from Israel, who is for the yes.
Thank you very much. I don't have a, oh, thank you. Can I have my slides? So I do not have to tell this audience that geographic atrophy causes progressive, irreversible loss of vision. In a retrospective cohort study using anonymized data from the ERM system in the UK, Usha Chakravarti showed the impact of GA on visual acuity and function. The data was collected in 10 clinical sites in the US from 2000 till 2016, and those were patients with geographic atrophy. 15% of the patients who had good functional visual acuity at study entry became legally blind by 6 years, and 67% of the patients who had good functional visual acuity at baseline lost their driving license by 1.6 years. In the Oaks and Derby trials, the primary outcome of least square mean change in geographic atrophy lesion area was met, with 22% reduction in the growth of the area of geographic atrophy in the Oaks study in the monthly treated versus the sham, and 19% reduction of the growth of the atrophy in the Derby trial in the monthly versus the sham. For the every other month, the results were also statistically significant, however, much less prominent. But for the visual acuity, the study have shown a significant decrease in visual acuity over time with no difference between the treated and the sham groups, and they all lost between 8 to 9 letters. I assume Professor Korobelnik will tell you that visual acuity is not a good parameter for patients with geographic atrophy, as those patients usually show marked fluctuations in visual acuity over the time. If we look at the patients that had subfoveal atrophy, 82% of them had a visual acuity of 2200 or better at study entry. But let's look at this small group of patients. 22% of the patients, it goes by itself, 22% of the patients that had a good visual acuity at study entry. So as I said before, all study participants lose vision, and this group, not as expected, had a severe loss of vision, and this was not expected according to their baseline good visual acuity. The NEI FDA gathered the first ophthalmic symposium on clinical trial design strategies and endpoints in 2006. Both of these federal agencies, as well as officials from the centers, Medicare and Medicaid, university scientists and clinicians, they all discussed, among other topics, how best to evaluate new treatments for AMD. After extensive discussions, the FDA agreed that an accepted clinical endpoint for GA could be the rate or extent of anatomic progression of GA in treatment and placebo groups. However, this would be accepted, understanding that this difference would represent a clinically relevant outcome, even without documentation of a vision function difference. As many trials for geographic atrophy failed to show any treatment benefit, another panel of specialists, the Delphi panel, gathered and discussed on identification, diagnosis, and treatment for patients with geographic atrophy. This group included 5 well-known optometrists, 5 comprehensive ophthalmologists, and 5 retina specialists. The panelists completed 3 surveys and 1 virtual meeting on 77 questions and statements regarding all stages of geographic atrophy. They have reached a consensus of 91% out of the 77 questions and statements. So the group agreed that geographic atrophy has a detrimental impact on a person's quality of life. To evaluate the treatment burden from the perspective of a patient with geographic atrophy, the panelists agreed that the quality of life questionnaire are useful. Panelists also indicated that best-corrected visual acuity does not reflect the impact of geographic atrophy on the patient's quality of life, but low luminance tests may be more useful to evaluate functional vision in patients with GA. And the ellipsoid zone has been proposed as a potential marker for evaluating AMD and linking the anatomical structure to the functional outcomes. But as I showed before, not only visual acuity declined. There was no difference in the Oak and Derby trial in all key secondary endpoints between the treated and the sham groups. No difference in monocular maximum reading speed, in the functional reading independence index, in the NEI visual functioning questionnaire, and in the mean threshold macular sensitivity in the microperimetry. So the Oaks and the study group tried to evaluate visual function of the centermost 4 points using microperimetry, and they showed a correlation with visual acuity. But this was only a post-hoc analysis, and similar results they have shown for 16 other chosen points, again, a post-hoc analysis. But the truth is that the 24 months differences between treatment group and sham in mean threshold sensitivity as assessed by the microperimetry was not significant. And compared with sham, the difference in the mean change in the number of scotomatous points in the junctional zone was not significant with pegcetacoplan monthly versus the sham. As you can see here, the p-values were 0.3 and 0.71 for both groups. Ursula Schmidt-Erfurth and her group published a very nice paper on the disease activity and therapeutic response to pegcetacoplan for GA identified by deep learning-based analysis of OCT. Again, this was a post-hoc analysis on a subset of 75% of patients of the study population of the Oak and Derby trial. They wanted to quantify the morphological changes of the photoreceptors and the RP layers under pegcetacoplan therapy in GA using the deep learning-based analysis of OCT images. The deep learning segmentation of RP loss and photoreceptor degeneration defined as loss of the ellipsoid zone, the easy layer on OCT, over 24 months. Professor Korobelnik will probably also show this graph showing that was in regard with photoreceptor loss, there was a 77% reduction in the photoreceptor loss in the pegcetacoplan monthly versus the sham group, and 36% reduction in the RPE loss in the pegcetacoplan monthly versus the sham. However, this algorithm was never externally validated. The Delphi committee, to which I have alluded before, stated that AI is still a significantly and rapidly developing area that needs further validation before it's standardized use in clinical trials. And the validation sets for the easy integrity analysis should use real-world data and be standardized for use across AI platforms. And just to mention a new AI validation committee under the International Retinal Imaging Society that is working in collaboration with other companies to validate AI algorithms. So the EMA, as you all know, did not approve the use of pegcetacoplan, stating that although the studies showed the safe over slow the growth of geographic atrophy lesions, this did not lead to a clinically meaningful benefit for the patients. It was noted that benefits of a treatment should impact patients' everyday functioning, and this was not demonstrated in these studies. Four esteemed retina specialists published just recently a perspective on drug approval for the treatment of geographic atrophy. The aim was to discuss the clinical trial results leading to the US FDA approval of the anti-complement therapies for GA. And they stated that although the ACP and the pegcetacoplan are the first FDA-approved treatments for GA, the results from the clinical trials failed to show any functional improvement after 1 and 2 years respectively. They have raised the question, do these drugs truly represent a clinically relevant outcome? And they've also stated the importance of ongoing clinical research that more closely pins anatomic features to geographic atrophy to functional outcomes. Ladd and Chakravarty published on how might clinical trials demonstrate the functional benefit. We're all looking for functional outcomes. So they suggested that location of geographic atrophy may be as important or even more important to reading speed than the size of the scotoma, identifying features in geographic atrophy patients with good visual acuity that specifically predict vision loss regardless of the GA expansion rates. And future clinical trials might focus on merging the FAF with OCT imaging to validate the geographic atrophy expansion rates and use of biomarkers such as photoreceptors loss. So in order to show some improvement in visual function following therapy, I think our goal for future trials would be to consider carefully the location and structure of the GA lesions. We know that unifocal subfoveal lesions have a good correlation between GA expansion rates and visual acuity decline. The location of GA should be paired with appropriate functional outcomes, such as GA to the right of the fixation with the corresponding scotoma to the left. We should always use the low luminance test and the macular sensitivity evaluated by the microperimetry. So in conclusion, I think that functional results are crucial to the patient, and I would just like to raise 3 questions. Does any of those patients receiving monthly or every 6 weeks or every 2 months is satisfied with the results? Do you think they will continue the treatment for years in spite of severe decline in vision? And finally, I think that patient compliance will not last without functional results, and treatments will not last without a clinical benefit to the patient. So my answer to the question, functional outcomes need to be used for assessment of treatment effects of drugs for non-neovascular AMD, is definitely yes. So thank you for your attention.
Thank you very much, Michaella, and let's make it different. I fully agree with you.
Oh, good.
Okay? So instead of talking of non-neovascular AMD, I decided to talk about neovascular AMD. So that will enlarge the debate about the evaluation and function. Your talk was perfect, and I follow you at each and every step. But what about neovascular AMD? These are my disclosures. So in treatment of neovascular AMD, is function important to evaluate and decide what we do? So the treatment of neovascular AMD is of course related to repeating intravitreal injections of VEGF inhibitors. This decreases in exudation, and in the best case, it improves or it maintains visual acuity. The mean BCVA with the drugs that we have now is very similar to the comparator, which is aflibercept 2 milligram. There is no difference for brolucizumab, for faricimab, or for aflibercept 8 milligram as compared to aflibercept 2 milligram during those trials, with different retreatment criteria that I will comment a little bit longer. So that's the point. Retreatment criteria in those trials, what are they, and is it something that we can do in our real life? So first, faricimab, Tenaya, and Lucerne, the retreatment criteria are CST or BCVA or new hemorrhages during the first year, and during the second year you can expand or reduce the interval. But what is BCVA? In fact, it is at least 5 letters compared to the mean visual acuity of the last 2 visits, or at least it is at least 10 letters compared to the lowest visual acuity of the last 2 visits. Do we do that in real life? Never. PULSAR, the retreatment criteria for reducing the interval or expanding the interval during year 2 are well defined here. What is it exactly? It's more than 5-letter loss compared to the best corrected visual acuity at week 12. So when you follow a patient for 1 year, will you look back to the visual acuity at week 12 to evaluate if it's getting better, worse? More than 5 letters? Why not at least 5 letters, more than 5 letters? So this is very different. And in real life, for wet AMD, again, and that's just to enlarge the debate, for real life, visual acuity fluctuates a lot. Those patients are old. You have to remember the mean age at baseline for wet AMD is 80 years old. Those patients have stress. The technician, the orthoptist, the optometrist that is evaluating visual acuity may be more or less motivated. You change rooms, it's not the same light, it's not the same distance exactly, so this fluctuates a lot. It takes time in a busy clinic. And do you do just visual acuity, or do you try to refract the patients to have best corrected visual acuity at each time, which is really time consuming? And which chart do you use? Do you use the Snellen, ETDRS, or another? And finally, those techniques are not standardized in daily practice as they are in clinical trials. Look at this visual acuity. They are from the lampalizumab trials. So some of those patients during the GA evolution of the disease, they have better visual acuity at some time points and lower visual acuity at some time points. It's really widespread. This really fluctuates. So the comparison between OCT only and OCT plus visual acuity was done by a study in France, in Lyon, where 142 eyes with wet AMD were evaluated with OCT only, and then OCT plus visual acuity. And does it change the final decision to treat or not to treat? And these are the results. You see on the left of the graph that 93% of the decisions were made on OCT only, and only 7% were modified by visual acuity. And by modified, it is not very clear in the paper which way it was modified, but it was modified. And you see that depending on the type of CNV on the right of the graph, type 2, type 3 mixed OCT is enough. Type 1, it's okay, OCT only in 90% of the patients, 11% where OCT plus visual acuity was changing the final decision. And this is the mean visual acuity when correlating visual acuity and CRT, and you see that it's really completely widespread. There is no direct correlation, not direct obvious correlation between the thickness and the visual acuity in this population. So as a conclusion, and once again to open the debate and to enlarge the debate, functional outcomes need to be used for assessment of, it was non-neovascular, it was neovascular AMD, and my answer is no. Visual acuity is not important to evaluate disease activity in wet AMD. Thank you.
Any questions from the audience?
I hope you disagree.
Okay, I do have a question. Don't you think that functional, that parameter in all the studies, the problem is that it's too short time, but in 5 years' time, for example, if we change the frame time, it's going to change, and functional parameters are going to be an issue, because we know that 50% of the patients will lose vision in 2 years' time. So when you expand that?
You mean about wet AMD, right?
No, dry.
Dry. At the moment, as Michaella said, I think that the tools that we use to evaluate function have limitations. And because of that, of course, we treat patients to preserve vision. But because of the limit of those tools, ETDRS, microperimetry, etc., it's very challenging to grade the activity and the capacity of the patients. But at the end of the time, I agree that what we look for is preserving function. But probably we need new tools. And when I say new tools, I don't know which ones.
Well, when I prepared this talk, I went deeply into the functional tests that may show some benefit. And I think after seeing all, I thought maybe the microperimetry, evaluating only the very, very center, but with pre-specified, of course, points, and maybe would be a good functional test to evaluate potential efficacy. The problem is that I don't see how in the clinical setup we perform microperimetry to these patients. I mean, it's time-consuming, it takes a lot of time. So in a trial, it is possible, but I don't know how we should do it in the clinical setup.
I think it's not feasible. Or maybe once a year, but even once a year when you have many patients, it's complicated. It's a very difficult test. I mean, you should try it. It's very difficult.
Patti?
I think maybe not in the clinical setup, but just for the clinical trials to be approved. So once we have the results and we know that it's working, and there's another thing that might be also interesting, which is not the 4 points in the center, but the peripheral.
Correct.
Okay, we speak about scotoma. It's not the same to have this scotoma than this scotoma. So I think that's also something, and in fact, there was results about this parameter.
I agree, especially in the junctional zone between the geographic atrophy and the
That's
good
where you
retina.
see the growth.
That's where you see the growth, and that's where you can distinguish a difference between maybe a potential benefit of a drug to the non-treated.
Patricia.
I have a comment, and I would like to know your really opinion, because we've been debating this morning about the functional test and how to really measure the function for the approval of new treatments for the EMA, for example, because we had the problem with pegcetacoplan. So I think the problem is not to measure the function. I think it's important. The problem is that we don't know how to measure it, really, to demonstrate a change. And on the other side, what about the stability of a patient? I'm considering just the approval point of new treatments. Do you think that demonstrating a stabilization of the function with whatever method that we discussed that it could be measured would be interesting or enough to really have a efficient treatment?
Stabilization of the function, you want to test it with the quality of life questionnaire?
Or with any visual test, low luminance together with microperimetry, I don't know, or a mix of tests, I don't know. It's just to know your opinion about the situation, you know.
Can I say? So I think that also as stated by some committees, the quality of life questionnaire, which is asking many questions regarding the function and the daily life activities, is quite, I wouldn't say accurate, but may give you some clue whether a patient benefits from a treatment if the disease is stable or it progresses. So I think this should be implemented, and unfortunately in the Oaks and Derby trial, there was no difference in the quality of life questionnaire between the treated and the sham group. So I think this would be, and the low luminance is also another parameter which may show a mild difference between a benefit difference.
I think that stabilization, if it's really stable, that would be great.
Of course.
That's what I told the patients that we recruited in the trials. I told them the drug, we believe the drug works, and it will slow down the disease, and in the best case, it will stabilize. So that would be, I think that would be more than enough, because natural history is really decreasing. But that's not what we have at the moment.
I think that the importance of having some functional outcome is really crucial for the patient. I honestly think that many of these patients that get pegcetacoplan, I think after 1 or 2 years, seeing that their vision is declining, they would stop the treatment. I mean, how can I convince someone who's losing vision just by telling him that maybe if he didn't get the treatment, he would lose more vision? I think that's not strong enough to show him that the treatment is efficacious. But maybe if I have some other parameters, that would be more convincing.
I agree. Maybe a tool with artificial intelligence to modelize what would be the progression without treatment, and to show that with the treatment it will go that way. But it's complicated for those patients to understand that, to show the size of the lesion, the rate of progression. I think it's too complicated.
I think it's too early, but some groups are working, engineering groups are working in designing AI tools to just try to show some activities of the patients. Probably this is the future, to try to have new tests that can evaluate the function, not only with direct measurements of what we consider now visual acuity or best corrected visual acuity or the visual function. And probably it will work, I don't know.
I agree that if we can show the patient something done by AI, that the treatment is really slowing the progression, it would be more convincing. I mean, patients, you know, they come with the OCTs. I mean, those are the neovascular. They tell me there is fluid, there's no fluid. I mean, they kind of get used to it very quickly. So I think they will also like to see something more evident for their treatment for GA.
Yes, I'd like to do some comments on what to tell people to adhere to therapy, which is going to be very difficult. I truly believe on the artificial intelligence for that role. However, I'm not yet sure that the predicting models from scratch will work. So for me, the best thing is to have accurate measurements from previous historical slopes. So we have the chance of having a historical slope, considering that short-term GA grows linear, short-term. So we can compare before therapy and after therapy. And if we have a beautiful decline, that's probably the best we can offer to people. And what I tell to my patients is, I'm trying to get you in 2-3 years in a better position for new drugs. So I'm gaining time for you to arrive to better drugs in a better position. I'm not pretending to treat you with this all life, just gaining time. So I think those things, if we can show the slope, that's probably the most useful thing right now.
So you're using AI to do it?
Mm-hmm. Yes, especially, I will discuss a bit on that, but the ideal patients that we want to treat are the very fast progressors. And the very fast progressors sometimes are very difficult to measure them manually. The beautiful ones who can you measure very well, those don't progress very fast. So hopefully those automatic segmentation AI will help us. And also, I know how to do it, I have the time to do it, but 99% of the people don't have the time to measure manually lesions. That's a nightmare, and I do it when I'm very motivated. So we need something that you just press a button and you have a number, right. And then you have the slopes, and that's helpful, yeah.
But still at the end of the day, Jordi, those patients, they lose function, and the one that I recruited, they all told me, I'm not seeing better. And I told them, but I told you
yeah.
that you were not going to see yeah. better, but that we try to avoid things getting much worse. This is complex message.
Right, yeah, that's why, because we cannot rely on the faith of the patient that you would have been worse. That's why I would like to use the slope, previous and after, to say, look, you would be there and now you're here. So you're losing, but you're losing less, and we may be using another drug for you in a relatively short time, hopefully.
I think we'll continue this discussion in the last talk, I guess.
Yeah.
So the next debate is on photomodulation is a viable treatment in non-neovascular AMD, and the yes side will be presented by David Almeida from the US.
Wonderful. Thank you very much. Great to be back here, and thanks for the invitation to debate what is the most recent FDA approval in the United States, photobiomodulation. I'm taking the yes position, so yes, it is a viable treatment in non-neovascular AMD. See if you guys agree. These are my conflicts of interest. None of them are related to this therapy. So this is the Valeda light delivery system. It really comes on three major things that were asked for. One, all the patients with AMD, 90% are dry. Of all the patients with AMD, 90% have limited options. Yet 100% of these patients look for better options to treat their AMD. So here comes Valeda with a 560, a 660, and an 850, a light. So the plausible biological mechanism for the light therapy is really around targeting mitochondria, basically an energy rescue to minimize oxidative stress by stimulating cytochrome C and having more energy. So you really think of like an ischemic energy response. When you look at every paper in PubMed that's ever been published on light therapy, and you do a word map, this is what you get. And so sometimes when you don't see one big word pop out, it can tell you that this is like variable, right? There's a lot of things going on here. And we look at some of the data. We look at in the incident of geographic atrophy, there seems to be some protective effect going on there. And if we look at actually individual patients, right, the drusen volume seems to be reduced, but we also don't really care about drusen volume because it's not really a functional endpoint, and it has a high variability signal. So If we take it further, what did light sight 3 really show? So that on average, patients gain up almost 6 letters, and half the patients respond, and you see a reduction in almost 3/4. So this comes with very good safety signals, but with some potential concerns. So the CNV conversion rate was higher at 5.4 versus 1.8%. And there's also, I always, when patients ask about this, I always do an analogy to a chiropractic adjustment. You're going to usually, patients seem to show some benefit. They seem to have felt some benefit, then it wears off until you redo the therapy again. So this is something that patients seem to understand. When we look at the patients in the trial, we can see that we're seeing a decrease in drusen volume, and therefore a lack of progression to IRORA and CRORA states. It's a perfect segue from the excellent debate that we just saw here, because when we're looking at a value proposition, like why are we debating this topic right here? This is because of this value proposition that compared to the two that we have, whether it's ACP or pegcetacoplan, we don't have a great value proposition for either of those drugs. When you compare the safety and the benefits of Valeda, we start seeing, maybe there is something here that, thinking about a bridge to better therapies, this one seems to be at least very, very safe. And why is photobiomodulation a viable treatment? Really, when you put it all together, let's move over to the safety data, because when we saw from the complement inhibitors, where you're looking at C3 or C5, the safety there is more complex, whereas in light sight 3 shows really favorable safety. So for safety, efficacy, and the fact that patients are asking for something that we don't have. Retina specialists and comprehensive ophthalmologists are asking for a revenue stream that's not CMS dependent, so they have that. So even though the science seems to have some, it's not perfect, there's multiple facets here that are contributing value to the patient. So I see this as a bridge to better therapies, and interested to see the other side. Thank you so much for your attention.
Thank you. Next speaker is Jordi Monés for the no.
Yes, thank you very much. I need to declare something. When I presented the controversies, I always present something I believe in. I'm not playing a role. So if I'm against this or I question this, it's because I do believe it. It's not I'm playing a role. So I will question the results on the light side trials and based on the paper mainly. So these are my disclosures, no one directly related to this. So the main claims of photobiomodulation are 3: gains in vision, prevention of GA, and disappearance of drusen. So let's go to visual gains. So at primary endpoint, there was a gain on the treated patients of 5.4, and on the sham, a gain of 3. So there was something difference of letters. And at 24 months, there was a 5-letter difference on BCVA. There was no difference in anything else. Low luminance, reading speed, quality of life, contrast sensitivity. We know by other studies like Macular that they studied interclass correlation coefficients and the limits of agreement to assess repeatability, that the limits of agreement and the normal fluctuation of those patients are 5 letters. And coefficients of repeatability are among 9, 8 letters. So considering that those changes of 2, 3 letters and 5 can be perfectly within the normal variance on these kind of patients and just a matter of chance. So then, for example, on gaining on 10, 14 letters, the sham gained 10 letters and 14, the same level as the treated patients. And those differences with both groups are within a small number of letters of difference. So there are also inconsistencies. Sometimes I speak on eyes, sometimes I speak on patients. So there, in the paper, there are many inconsistencies that I'm not sure how the reviewers pass it. You will see. So also in the paper, in 3 different places, there are 3 different numbers of treated eyes. So sorry, I jumped one slide. Let me go back. So eyes are taken individually, but both eyes of the same patient are taken. So there is a double organ bias. They address it statistically, but it's not clear if they do it for all the variability. So the sample is small, and with this is even smaller, because at least 50% of the patients, both eyes were used. And there were dropouts, and those dropouts of patients mean dropouts of 2 eyes. So the dropouts of eyes were significant. So I was telling before, in 3 different places of the paper, 3 different number of patients treated: 138, 148, 145, 144, 142. We don't know which was the real number. Then the entry criteria was the Beckman, yes, but soft drusen per se doesn't mean much, and that was the entry criteria. So when you say soft drusen, per se doesn't mean much. These are soft drusen all of them, and they're gonna behave very different. The prognosis is very different. It's like saying you have a car. Those are cars, and they will not perform. They're very different animals. So we have no information how those drusen were. But not only that, there was no information on the balance on the both groups. No one. The only baseline characteristic was the color of the eyes. Nothing about the drusen. So then when we go to prevention of atrophy, in some places of the paper you have it's 4 patients baseline at the PBM, 3 in the sham. In another place of the paper it's 6 patients and 5. And with such a small number of patients, this is so relevant. Also, the baseline lesion size, it's 0.2 in one and 1.2 in the other. Very different baseline GA of those whatever patients were. So there is no definition of GA onset. They don't say if it's Aurora to 50 Aurora, if it's Aurora. In the presentation, they talk on Aurora. There is no definition of what is new GA. Let's go to this graph and pay attention to this. They say numerical reduction of GA of 19%. And first, a square root analysis is not microns, it's millimeters per year. First mistake. Second one, they have this baseline, millimeters square, and then at month 9, the calculations of the square root is wrong. It's not 0.4, it's 0.1 millimeters per year. So that calculation is wrong. And then, in the other group, at month 9, GA is smaller than at baseline for the treatment group. And they don't say that. They said it's bigger. All numbers are wrong. So you cannot trust this statement. So it's wrong data, wrong calculations, wrong methodology. You cannot say anything about GA with this kind of graph. These are representative images for GA. Above, representative of PBM. Below, of sham. And they compare in absolute numbers the growth, such a small lesion with such big lesion. So this isn't comparable. You cannot compare with absolute numbers a lesion that by absolute numbers will grow like crazy compared to the small one. And that's representative for each. Then at baseline, drusen volume in the sham was double than in the other group. And changes are 0.5. Over 0.96, this is a change of 5%, and they claim changes in volume of the drusen. So then, claiming that in the sham the volume increases, and they put the representative picture. Of course, increases. This is wet. That's not the drusen, that became too wet. So that's in the sham, and they put it later on the paper that went to the wet, but they show it as a comparison. And now, showing that the PBM decreases drusen. Okay, take this image. This is OCT. Okay? That's what they show. Let me show you this. Subdrusen massively disappear. Subdrusen massively disappear. Drusenoid PED massively gone. Even Aurora reversion. Another one, gone. Aurora reversion. I just published this. This is a spontaneous drusen regression without atrophy. It happens, 20% of drusen. So those things could be just by chance because we don't know which group, we have no baseline characteristics in both groups. So very inconsistent and could be by chance. Bas Sada wrote a letter in JAMA, and he found, for example, many things, but he picked something that despite that these patients were intermediate AMD and despite that they had non-foveal GA, visual acuity in 30% of people with 20/40 or less. In those limits, changes of 5 letters are completely normal variability. And they questioned the trial design, the sample size, the clinical relevance, and even they raised a concern on chronic application of infrared light to these eyes. And then meta-analysis of the 3 randomized trials. The pool analysis showed 1.76 letters of difference. The trial sequential analysis showed that current samples were insufficient. No significant difference were observed in GA area. The minimal clinical important difference showed that this difference did not translate into clinical. And in the quality assessment, all studies were deemed to have a high risk of bias. So in summary, sample size is small and dropouts, double organ bias, 2 eyes use of same patient, regression to the mean gains even at 1 month in both groups, 5-letter differences within the normal variance in this population, no characterization of any drusen, no baseline characteristics of drusen in both sides, and that's crucial to know if those differences were true, no definitions of new GA, and statements made out of weak methodology, wrong numbers, and inconsistent data. So benefits may be due to chance, statistical noise, or placebo. Thank you.
I totally agree with you. I read also Sada's paper in the JAMA, and he points out many points that are actually, it's hard to understand how it was approved by the FDA.
And how the paper went through the reviewers.
With such a small number of patients, honestly, such a small number with so much data missing that may enlighten completely different results, with a drop of, like you said, nearly 20% of patients. We don't know when did they drop. And also, what you did not mention is the treated group. Well, 5 of them developed macular neovascularization.
That showed the increased rate, yeah.
Yeah.
Well, I didn't claim that because with those numbers, I didn't want to make that any point.
Right.
Because, I mean, if we play with numbers like them, we would say you have 5 times more of wet.
Correct.
But I didn't put it because I don't think that those numbers support that either.
I know. So, and also the fact that they had a visual acuity of 20/40 is a bit strange, as they did not have geographic atrophy. Right. It was just drusen. Right. So it makes all the results very, I don't know, it's hard to believe. So I'm asking myself, how did the FDA approve this treatment?
I think it's important because you bring up really good points, Michaella, and it was a great presentation, Jordi. I was not an investigator. I don't use it. I'm actually agree with you guys, but you know, like you have to.
You had to play the role.
Yeah, I don't want to ruin it, so I don't use it. So I called David Boyer and Diana Doe, and I talked to them for a long time yesterday, you know, about the nuance of this. And I think there's a few things you have to unpack, and I think it's easier if you start holistically and get to specifics. The first one is like, well, all your comments are all like generalized to GA, right? Intervisit variability, inaccurate GA with light. Like these are all things we know from any GA trial, right? So like you can't block a therapy just because you have a trouble with trial design. So I think you can push those out very easy. The most of the inaccuracies are Lighthouse 2, not Lighthouse 3. Lighthouse 3 is the one we're talking about, right? So you can push those out. So then what are you left with? You're left with a trial that doesn't have all the patients probably in there in those aspects, but you still have a very safe signal, right? So I think this is where we struggle with, because once again, retina specialists, comprehensive ophthalmology patients are asking us for this type of treatment. Clearly the safety is good here, and so you have to, I think, really think about almost that in North America that we have a really hard time with harm reduction, right? You know, so, but I think of this like harm reduction. If I give somebody PBM, they don't get like maybe a complement inhibitor, maybe they're safer now, you know? So there's complexity in terms of the algorithm, what patients could be accessible for. So I think this is some of the, and having talked with Sada and agreeing with many of the points there too, I think this is some of the things that I came up with as potential reasons, because it's a strange approval based on such a small number and with a lot of outliers too, which is what, but safety, you know, is I think what the driving point.
Barry?
First, you go.
Jordi, well done. David, you've been given a curveball, and it's late in the day, so we're sorry, I think, on behalf of everybody here. But I think that there is a serious thing here, and we have a duty as ophthalmologists, as a community, to protect a very vulnerable population. This is the most vulnerable population that we see on a regular basis. And this paper, Lightsight 3, is one of the worst, or one of the best examples of bad medicine. It's a fantastic paper. To read it as to tell you how not to do a study and how not to write a paper. As Jordi's pointed out, the study tries to say they were equally balanced groups of patients. Best corrected visual acuity, they were. They forgot to mention that in the appendices, the low luminance, which we probably consider probably a better marker of geographic atrophy, is a whole line of difference between them. So I think we've got to protect our patients from it. There may well be something in it. Mitochondrial enhancement, we're believing in that. This is what PBM does. So I think we need more study on it. We've got to protect that vulnerable population, and we've got to look into this more rather than offer it as a treatment. For any of those people who are in the audience who's still keen to use it, I urge you to look up Larry Little. Larry Little is a physician in the US who was given 14 years by a South Dakota court for selling photobiomodulation as a treatment for numerous medical conditions. And in that ruling, the judge mentioned two things: overselling the benefits in a vulnerable population. And I think PBM in GA with 140 patients, maybe 142, 144, who knows, Jordi? It could be any number, couldn't it?
And we're eyes, not even patients.
Exactly, but remember the ruling, vulnerable population, overselling the benefits, and I think we do have a duty. So again, sorry, David, I think you were given a curveball. Jordi, thank you for pointing all of this out.
And I just want to make a comment before Barry that you're talking about geographic atrophy, but the amount of patients who had geographic atrophy was very small in that study, especially at study entry. So most of them just had drusen.
No, they were small and inconsistent numbers. Any calculation on the GA side was incredibly wrong, and I don't know what the reviewers did, because no number matches.
When you think of who's buying it too, Jordi, like right now, like retina specialists haven't bought any of these machines, right? This is bought by optometrists and comprehensive ophthalmologists, and I think that tells a lot of, where, because you're right, because yeah. So I agree.
Barry.
Well, first I want to acknowledge David Almeida and what a hero he is. That was supposed to be my job, but when he said he was coming, I said, would you mind doing this? So thank you very much, because otherwise that would be me sitting really in his position, because somebody had to do it. Number one. Number two is, ironically, Kim Kern, who is sort of the originator of photobiomodulation for the eye, was at Case Western, but we recruited him to UC Irvine, so he's in my department. But he was sort of the scientist, the PhD that started this, and he thinks this is a load of crap, this study. And I was with Vasada literally last Saturday. I was at Doheny, and he is very strident about this. He objects also to the financial model that you elaborated a little bit. Unfortunately, because it's not approved, meaning it's approved by the FDA, but no insurer is paying for it in the United States, this has become a business model, quite honestly, and patients are being charged $2,000 per session, and it's just a way to make cash. So there's nothing to like about this, quite honestly. And Jordi, I salute you, did a great job. David, you did a great job, given the circumstances. But it's awkward for all of us. Unfortunately, we thought it was important to have here, with all due respect to people here, because it's becoming sort of popular in Europe, and I'm worried about it, because it so far doesn't have much traction in the United States. We're worried that Europe is leading the way in a bad way this time.
No, great points, Barry. And it reminds me of that quote of, like, you have to be able to know that the world's going to hell in a handbasket, still do everything in the opposite. So you have to know that this is out there, but at the same time, doesn't mean you have to do it or be part of it.
Great, thank you.
Yes, I want to say two things. First of all, I'm surprised, really deadly surprised how it was accepted to the journal. And I'm asking myself if we don't have the responsibility to write correspondence about it. Just pointing out everything that you show, Jordi.
Well, I need to tell you, I read all this because you asked me. I didn't want even to lose my time on getting that deep in the paper, because I thought science was weak. But I did it because you asked me to do it, so I had to do it. So
thank you.
So, yeah.
I might want something else next time.
But yeah, probably a correspondence letter would be, someone should do it. I think that in some way Bas did it indirectly with what he published in JAMA.
Yeah, and the other thing is the fact that we put it into the program was because we were asked about it so many times. So we thought, if this is not a controversial issue, what is? And it reminds me a little bit about treatments of treatments like SLT, for example, for glaucoma. Not SLT, there is a new Belkin laser, you know, a laser that uses CO2 and is supposed to, for glaucoma, and it's like gaining so much popularity, and it was bought by a company, and it was supposed to just identify the Schlem canal exactly and open it, or I don't know what, and someone did it on closed eyelids now, and they just showed it in a recent meeting, and it just burned the eyelid, so it's not specific at all. The problem with all this treatment that you don't see anything, you know, like PDT, like it's so difficult to know exactly what's the mere action. So that's why we put it into the program, because we see that it gains popularity, and we just thought that we should look at it very carefully, like both of you did, and thank you for that.
And you brought up a good point in that. Patients ask about it a lot, right? I ask about it at least once a day, and I tell them, look, I've been a PI of over 130 clinical trials, and maybe 25 were GA or AMD. I've never been involved in this, so I don't believe in it. So,
and the other peculiarity of this kind of therapy is that most of the people that use it will never be in this room. No, because I don't know many retina specialists that claim they do it, at least publicly. I don't think many retina experts do this, or they say they do it.
Well, you know, I think that young retina specialists that come, they see a treatment. There was a paper in Retina, you know, it's
approved
by the FDA. They make money, approved by the FDA, accepted by the journal, by Sandy Brooker. What else? I mean, why not? So,
but it belongs more to anterior segment doctors, to a regular ophthalmologist.
Yeah,
they say it doesn't hurt. Well, a glass of water doesn't hurt either, and we don't charge for that.
Yeah.
So that's the kind of ophthalmologists that do it, and they don't have the critical review of doing it according to science. So that's like a side. This kind of therapy is a bit a side of the science circuit.
Yeah, you're absolutely right.
Yeah.
I think
So I stay?
we are going to move to the next one, maybe.
Yeah, so I stay on stage.
Thank you. It was a very, very interesting debate.
Thank you.
I think Anat has to be
So
very,
now
very happy.
I think it's my
Now
turn
let's
again.
go for the last one. It's a complement inhibition for geographic atrophy has more benefit than risk. Jordi, Monés,
Yes.
going for the yes.
Sorry, it's not in the beginning.
Okay, guys, please notice, this is the most important debate of the meeting.
I'm trying to get into my first slide. Sorry. Sorry, I think. Oh. All right. No. Okay. So as I stated before, whatever I defend in controversies is what I believe. So I'm going to defend that complement inhibition for GA has more benefits than risk. These are my financial disclosures. Many are related to GA. AMD is a true epidemic. We have no therapy for GA. We know that. By genetics, we all know that complement is paramount in the pathogenesis of GA. By histopathology, the same. Targeting complement has been attempted in many trials. Some have succeeded, some have failed. 2 approved drugs we have in the market, and 2 other coming, very promising therapies from Annexon and Johnson are coming. And so where is the problem? The problem first is that feeling that the deltas are not good enough on the primary endpoints, that they're not that convincing. That's one problem. The second problem, that there is no visual function benefit in the overall group. That's the other problem. And the third problem is that it's no safe profile because we have the vasculitis in some patients. Okay, so we'll address all that. So let's go now to anti-VEGF therapy and endophthalmitis. It's 1 out of 3,000, 1 out of 5,000. Do we question anti-VEGF therapy because of endophthalmitis? No, not at all. Because we do benefit to patients, which balances the risk-benefit, and because we treat patients that are at risk of losing vision, and we don't treat patients that they're not at risk of losing vision. So we treat patients like this, and we don't treat patients like that. And this is obvious. And that's why the ratio is good. So what are the 2 mistakes when judging anti-complement therapy? The first one is diagnosing GA as one thing. As I said before, GA is not one thing. there are many animals. So it's like what I was saying of the cars. So all these are cars. So GA behaves very different. And let me show you two patients, the same time lapse, and you'll see how different they are. And until now, patients like that were in the trials, these kind of progressions. One took the phobia with less than 2 years. The other one will take 10 years to take the phobia. So these are GA, both are GA. And these trials were designed many years ago, and this heterogeneity was not taken into account. So the trials have a lot of noise on patient recruitment. So the second mistake to judge complement therapy is using the primary endpoint as clinical guideline. No way. Primary endpoint is a statistical number to approve a therapy, but may not represent any single patient because it's an average of all the patients. So if we want to select which patients will get benefit, we need to look at the secondary endpoints. There we'll see what patients benefit more, which patients don't benefit. And again, the complex heterogeneity of the disease was not addressed. So that's why it's so difficult that in these noisy trials with so many patients differently, we'll have a functional benefit. So when we start using secondary endpoints and we cherry pick, yes, it's okay cherry picking because we don't want to treat everyone. So when we cherry pick people and we identify the best responders, for example, non-subfoveal, then the numbers become better. And then the longer the therapy is in those ideal patients, the more the benefit we have. And then on those patients, saving of tissue after 3 years can be 0.25 millimeters square. Those are thousands of cells, 12,000 RPE cells, 360 photoreceptors. That's a lot of tissue saving. And recently it was presented 4 years data on Gale, and this preservation of tissue reaches 3.16 millimeters square after 4 years. And what does it mean? 3.16 is 1.5 disc areas. It may be all the fovea. So that's a lot of tissue preserved after 4 years. So, and also when we saw the secondary endpoints, we realized that we are only targeting RPE. We are targeting photoreceptors. That was the beautiful word showed by Ursula. We are saving photoreceptors too, not only RPE. And that was also shown in Izerby on photoreceptors. So now let's go to visual function. Lampalizumab showed that there is a weak correlation between visual acuity and GA progression. That's very difficult because some lesions that progress a lot spare the fovea, for example, don't lose vision. But despite that, in certain subgroup analysis, there start being some differences of letters. And at 3 years, now this is at 24 months, at 3 years it was like 8 letters. And the chances of getting 200 over time was also very decreased. And that was an Izerby too. But let's go to microperimetry. That's probably the most piece of information. At 3 years, microperimetry, the center points, the 4 center points, the 16 center points became a statistical significant. And that's very relevant. And you see here in the graph. And the 4 center points being all preserved or being all gone correlates very well with visual acuity. If you have the 4 center points, you have a visual acuity of 68 letters. If 4 are gone, of 47. So that's very meaningful. And the chances of preserving the 4 center points were it was about 35% favoring the therapy and about 45% of the 16 center points. That's function. It's not true anymore that there is no functional signal. It takes time, that's true, but there is functional signal in complement therapy. Also, it was seen that after 18 months and the more the therapy goes, there was preservation of areas around the lesion. So would I treat everyone? Of course not. This patient, for example, that's a collapsed retinoid after 18 months, same stuff. After 5 years, same stuff, same vision, no progression. This is GA, and you don't want to treat it. There is no rationale to treat this patient. But what about this one? Multifocal, extrafoveal, reticular drusen. Let me show you how this patient was just 8 months before. Much, much smaller. This lesion is progressing like crazy. And that patient will lose a lot of vision in a very short time. So, patient selection is more crucial than ever. So if we have the historical, things are very easy. Because we have the historical, we can tell if these patients are very slow, moderate progressors or fast progressors. When they're very small, very slow-in progressors, I would never treat them probably. When they're very fast progressors, I would treat them immediately, and in the middle, depending on other factors. And then, if you don't have the historical, then it's much more complicated, because you need to make a very complex matrix of many things, which is size, distance to fovea, percentage of the inner ring, phenotypes of the drusen, of the lesion size, of the shape, of the fluorescence, photoreceptor RPA ratio, if the patients have MMB associated, and the fellow eye. So it's very complex, but putting all that together, you can predict if some patients will go slow or go fast. So complement inhibition for geographic atrophy has more benefit than risk. For me, it's absolute yes, in the appropriate patients, of course. Thank you.
Okay, so I will be in favor of the no. If I can have my slides. Oops.
Take it, Jordi.
Yeah, and I will try to explain to you why I think it's not worth the risk for the benefit, the disclosures. So we have 2 drugs that are approved in the US, nowhere in Europe or in other countries except Australia now. And we have a lot of data from those trials that have been presented many times, just to compare that it's the drug versus sham for 2 years. The primary endpoint and the end of the placebo group is at 2 years. So we can project what is happening during year 3 or 4 or 5 or 6, but it's a projection, it's not the reality. We don't know the reality, in fact, because there is no placebo group anymore. So we have to stay with those data, where I agree, non-subfoveal seems to be more responsive than subfoveal, but subfoveal still have some kind of response. And amazingly, there is no difference between every month or every other month's treatment. You may expect some difference, there is no difference. So the extension is supposed to be good for the patients because they are all receiving the treatment, but in fact you lose the placebo, so you lose the powerful of the statistics. And this dot line, I don't buy it. I mean, it may be the reality, it may go up, it may go down during time. I don't buy it. So the difference, to me, stops at 2 years. So the benefit for visual function, as we measure it, and you've seen it many times, is 0 at 2 years, despite that difference. And when you look at BCVA, you look at reading speed, you look at functional reading, you look at macroperimetry, let's say it's simple, there is no difference with regard to those secondary endpoints. What about the risks? Well, you just look at the FDA document, it's well defined, and you didn't list all of them, Jordi. So endophthalmitis, retinal detachment, neovascular AMD, IOI, and elevated intraocular pressure. This is well defined at 18 months in Derby Oaks. So 18 months, you see that you have 10% of the patients that developed wet AMD in monthly as compared to 3% in the sham. So the treatment increases the risk of neovascular AMD, which will require treatment at a frequency that may vary a lot from one patient to another. Endophthalmitis, you're right, every time we do an injection, we take a risk. In the studies, the risk is the same as expected, 0.04 per injection. But we know that the endophthalmitis can be severe, not so severe, and very bad. So the risk can be really high of losing everything with the endophthalmitis. And the intraocular inflammation, I will come back to that. So why do we have CNV, MNV, when you inject a complement inhibitor? We don't really know. Are those patients with a quiescent MNV visible on OCTA before the treatment? We don't know. So should we do this OCTA before initiating? Maybe, we don't know. Should we do OCT during monitoring of those GA patients before each injection because they may induce wet AMD? Why not? And the need to treat the anti-VEGF plus the GA, the anti-complement, it's more risk, more burden, more the risk of complications. Endophthalmitis, of course, it's related to the procedure by itself. Also because it's in a vial, it's not in a pre-filled syringe, so the risk is increased as compared to PFS. And inflammation, not clear. Why is there inflammation? The anti-drug antibody at 2 years are 4% in OAKS, 2.5% in DERBY, so it's not related to those ADAs. Why this inflammation? We don't know exactly. The problem is that it can be very severe. Volume injected, there is another risk here. 100 microliters is a lot. Those patients really don't like the injection. It's painful. There is a risk of amaurosis during 1-2 minutes. And 1-2 minutes when you are completely black, it's a long time. And there are several cases of non-arterial NION that have been described in the literature related to this elevated intraocular pressure. So should you do an anterior chamber tap before each injection? That's what some people do in the US. What about the changes in the optic nerve head with time, with repeated spike of in pressure related to these injections that come every month or every other month? IOI, those cases are very impressive, I would say. Severe cases of occlusive vasculitis that occurred with diffuse intraocular inflammation, vitritis, anterior chamber. They are rare. They occur only with the first injection, apparently, mostly female. Why females? We don't know. And this is so bad that at the moment, as far as I know, in the US, they recommend to do the first injection in the fellow eye, in the bad eye, so that if it occurs, it's not going to jeopardize the vision of the good eye. And the competitor, well, we have less data on the competitor that is inhibiting C5, same visual acuity, benefit, same volume, same risk, despite probably less inflammation. So with all this, the European Medical Agency decided that the benefit-risk ratio was not in favor of the approval of the drugs. I agree that in some subgroups it may work. I agree that fast progressors are the target population, but has it been demonstrated that in fast progressors it works really? This is post-hoc analysis, and we know that in post-hoc analysis it's weak. So that's why the EMA said no to Syfovre, and that, expecting a no, that's why Izervay was not asked for the approval at the EMA. So at the moment in Europe, we don't have those drugs, and I think it's worth waiting for new studies, prospective, on fast progressors to demonstrate something. Until then, do they have more benefit than risk? I don't think so. Thank you.
So we'll begin the debate. Go ahead from the audience.
So great job, both of you.
Yeah.
This is theoretical, unfortunately, or fortunately for Europe at the time, but it's a real issue for us in the United States. It's transformed our practices. Patients that we used to see every 6 months that we're just seeing to make sure they hadn't converted to wet AMD, we're now seeing every 6 weeks, because most of us, of course, have chosen not to follow the guidelines of the clinical trials, which were every 4 weeks and every 8 weeks. So of course, as doctors, we said, oh, let's do every 6 weeks because it's less often, but maybe you get the benefit of the 4 weeks without doing it as infrequently as 8 weeks. It's a challenge, as you pointed out, JFK, that the Syfovre, the numbers keep going up. We're concerned about that risk of retinal vasculitis. I do typically, for Syfovre, inject the bad eye. I call it the crash test dummy eye. They've got one bad eye and one good eye, then I take the bad eye, which I have no intention of ever treating again, but I give it the first eye, first injection there, and then if it's safe, then I'll proceed with the fellow eye. So it's a challenge.
That's a very expensive crash test.
I don't disagree, but every crash test is expensive. When we crash your nice Peugeots and Citroëns, they cost money too. But again, so then the question is, ultimately, so many of us have initially was doing, so first of all, there's still a debate in the United States. There's still a chunk of people, many academic departments, mine's a little different, that are not injecting it at all. Most are injecting it belatedly. We weren't the first group to inject, but we did eventually start injecting. But what we don't know is the risk of Syfovre versus its mediocre but potentially less mediocre benefit compared to Izervay, which is safer but may be more mediocre than Syfovre in reducing the risk of progression of GA because the data is so thin. So it's a challenge. None of us know what to do. It takes many visits. Usually when I start discussion with a patient, I review to see if they have had progressive GA over the years. I show that to them. I initiate a conversation, and we don't do anything at that time. They come back 3 months later instead of 6 months later, and I have another conversation with them, frequently now with a family member, and we talk again, and then they come back a third time, and then we decide if we're going to initiate treatment or not. But these days, it tends to be more likely to be Izervay, just because I want to be safe. But the final thing on the injection, we discovered that 100 microliter injection, if you give it very slowly, like over 10 seconds, there's minimal pain. Took a while to learn that, but they tend not to black out their vision, and they tend to have very little pain from, amazingly, instead of giving the injection over 1 or 2 seconds, to just go slower. Over 10 seconds, they seem to tolerate it very well. But it's still a challenge for us all, because then, of course, finally, there's the patients that either convert to wet AMD because of the injections or have wet AMD already pre-existing, and then you have to balance the every 6-week injections of the drug and then the timing of their treat and extend interval of their wet AMD. So it's a mess. It's a challenge.
Barry, but I have a question. As you're probably injecting for the last 1.5 years or so, or maybe
more
even...
like last 6 to 9 months. It took me a while. It was last summer. I can tell you that last summer when we saw it at ASRS and saw those results, that alarmed us all. So it's been more like less than a year that I've been injecting.
So my question is, within a year, do you think all of these patients will continue the treatment? I mean, they all lose vision.
So far, none of them have stopped. What we're missing still, what wasn't addressed, is some sort of automated algorithm in our OCT machines. And I don't even care if they count every little aspect of GA. Pick an area, draw a circle around something normal, and see if what that rate of that area is progressing or not. So I could show my patients, I could say, Mrs. Jones, here, this is what your rate of progression of GA was 6 months ago. Now you've gotten 4 injections over 6 months, and it's the same rate. So far, no benefit. Let's do it for 6 more months. But if there's no benefit seen then, let's stop doing it. I have no way of knowing, which is incredibly frustrating to me, but the patients so far, again, with about a year's of experience, they're all staying on. Nobody has yet abandoned the therapy. Now, 2 and 3 years out, they may, but I'm choosing patients that I have shown them over the last 3 years that they have progressed. I show them their GA on those OCT, on the infrared image that we have in the upper left, and I use that. Those are the ones that I've chosen to treat, not the ones that have stable GA that have not progressed over years. It's difficult. Nobody has a good answer for this.
Barry, do you think that one of the companies will do a new trial on fast progressors? Because I agree that the post-hoc analyses are suggesting that there is a benefit for those patients. Right. So a new trial prospective with good criteria would be, but at the same time, if they do it, they take the risk to fail, which will be worse.
Yeah, so that's a challenge for the companies. And of course, what you addressed as well, but is still a mystery, is why do we accept a surrogate anatomic endpoint if there's not if it doesn't correlate as it should with a functional endpoint? So all this work and effort and all these injections we've done, and yet we don't know, over the overall patient population of the trials, there was no visual benefit. We know there had to be within that individuals who either stabilize their GA or improve their vision or something, but as it stands, it's a black box. We don't know which patients are really the best beneficiaries. We know that these rapid progressors are still identified, the quartiles, and some being more benefit than others, but we don't know how to track those patients. It's an incredibly frustrating and expensive and time-consuming experience, and it is throwing my clinic into complete disarray because I can't fit all my patients in anymore because suddenly patients that we used to see twice a year are showing up 8, 9, 10 times a year and getting injections. It's discombobulating.
So much to say that I have difficulties to remember. So first of all, regarding the injection itself, Barry, I heard Phil Rosenfeld in our webinar, the angiogenesis webinar that we did in our country, and he said that he always softened the eyes prior to injection, either with massage or with iopidine, and that, in his opinion, reduces the pain significantly. Secondly, and Jordi, I know you're doing a lot of these, when I did the first injections, the syringe actually jumped out of the needle because it was so viscous, and I needed to learn to really, touch it strongly and even touch the needle at first, at the conjunction to the syringe, in order for that not to happen. Later on, I learned how to do it. So this is another point, that it's very viscous. The second, I didn't treat many patients, but I treated only a handful. But I have to say that there is a huge placebo effect in my opinion, at least in my patients. 2 of the patients are claiming that they see much better, and they requested to start on the other eye because they feel that they see better. So I'm sure that in all the studies, people want so much to see better that the placebo effect takes place. And the other thing is that I think that the fast progressors is important, but the more important thing is the personality of the person. If the person comes to me and says, do whatever you can to even slow the progression, he is the patient that is suitable for treatment and will not stop. I'm never convincing the patients. I'm telling all of them that this exists, but I'm explaining everything to the ones who are really asking, and it's so important for them. Usually, it's people that already lost vision in one eye. And so that all was a comment. But I wanted to ask you, Jordi, and I keep asking you this question also in our weekly phone calls, but when you show this round area of GA and you said it's a collapsed drusen or drusenoid PED or whatever, how do you know that? What is your criteria to say that this area this patient should not be treated because it's not regular GA, rather it is a collapsed drusenoid? How do you know that without previous images?
Okay. So when you have a round GA, very well demarcated, on the OCT, the edges are very sharp from abnormal to normal. There is no transition age, meaning that transition zone, there is no action. It's dead and alive, very sharp. So it's nothing happening there. So those lesions are very, very slow. And also you see those GA, rounded GA with a ring of no drusen because they disappear when the drusenoid collapse. And then you see, it's very typical. So in the worst scenario that you were wrong, after 6 months, you will see the patient, and if you were wrong, you will see that the rate changes. So you always have this second chance of saying, okay, in 6 months, I will revisit my thinking, and this is what I do when I have a doubt. Okay, I'll see you in 4 or 6 months, I will recalculate, and I will tell you by the square root how annually you grow. But you can forecast sometimes, many times, and then you always have this double chance of proving after 6 months.
Because these will not grow, the ones that are drusenoid?
No, whenever you have GA secondary to soft drusen, especially those collapsed drusenoids, the progression is 0.1, 0.2 millimeters per year square root, typically. Some very, very few exceptions. If they have reticular drusen associated mixed patterns, then they may grow a bit faster. But when they're pure soft in the center, very likely they're going to be slow. I would not treat right away. But if I'm wrong and 6 months later the lesion surprisingly grew more, then I would change my mind.
So theoretically, these patients could have entered the trials and bring a worse outcome than the real outcome.
Oh no, that's what I pointed. And those trials have a lot of noise because they have slow progressors, fast progressors. So that's why you cannot get a functional signal. And also you pointed that only the proof is 2 years, but if, the trials also happen in wet and GA associated with wet. The trials last 2 years, but our patient vision is for 10 years. So we need to try to, predictions are not perfect, but we need to predict because life is longer than 2 years. So things that happen at the 3rd year, the 4th year are very meaningful. And the more time it goes, the more the benefit you see. And yes, convincing people and talking to people. First, as you said, Anna, they have to be highly motivated, and then you need to talk a lot. And so it's tedious, but some patients deserve it. And I told my patients, this is just for having you in 3 years in a better position for another drug. I don't expect you to be treating with this drug for a long time. I will have other drugs and I want you to be less bad in 3 years.
But I think that even for highly motivated patients, it's a real challenge to stay on treatment. I mean, the patients we selected to be included in the trials, we were very selective. We were very much looking for patients that were motivated to attend all the monthly visits, 2 years. We were promising them that they will get a benefit of the treatment, etc. And despite that, they realized that they were losing function and they were desperate, and all of them, except one, among 15 patients we included in both trials, all of them wanted to stop. And some of them we were able to say, okay, go to the 2 years and then you stop. And the others, they say, I just don't want any more of those injections, they are too painful. So I mean, what I mean is that even by being very selective on the motivation, we lost all of them at 2 years. So maybe we need to be even more motivated, identifying fast progressors.
Yeah.
Yes, please.
Sorry.
Jordi, it was just a corollary question to that drusenoid PED that would collapse and cause GA. Would that be the case also with vitelliform lesions? Because we see a lot of vitelliform degeneration accompanying AMD. So if they disappear, they always leave behind an area of GA. So do you feel that behaves similarly to drusenoid PED collapse?
The funny thing of vitelliform is that sometimes you have vitelliforms associated with drusenoid, but sometimes you have vitelliforms associated with reticular pseudodrusen phenotype. So when you have vitelliform with reticular phenotype, then you may have a central lesion that grows fast. That can be exceptional. But I think that the vitelliform per se doesn't tell the story. What tells the story, what is associated with it. If it's a drusenoid, soft drusenoid, or if it's a reticular pseudodrusen with vitelliform.
Last comment.
Yeah, just some general comments actually on this and the previous session on PBM. So I'm probably one of the rare retina specialists who've probably done a lot of PBM, but not yet done much with the intravitreal injections for GA. And I'm just amazed the amount of energy that's gone into the GA, promoting GA studies and the GA treatments, when we all see that the benefit to patients is so minimal. And in terms of the FDA approval is pretty blanket for the GA injections. It's not the secondary endpoints and the select patient group that Jordi is referring to, which I agree, that those patients probably do benefit. But if we're to protect patients, vulnerable patients, there's the potential for a lot of over-treatment of GA at huge expense, which I think that's what we need to be preventing patients from, vulnerable patients potentially losing out. Versus PBM, where the cost of PBM is probably less than 1 or 2 crash tests. And I think we have a duty to give patients information as to what's out there, what their options are, especially when they've got no other options. And from my point of view, I'm happy to talk about my experience, and hopefully I'll have more audit data, but when it comes to the PBM patients, I'm surprised when they've not felt a benefit or actually had a documented improvement. I'm more surprised when they're not getting that. It's just sharing my thoughts and experiences.
Thank you.
Well, you managed to introduce even bigger controversy on top of this already controversy. So again, I'll just say that the feeling in the United States in that healthcare system, these patients, by and large, the treatment is completely free because the insurance, Medicare plus supplemental covers it. And with the people that are doing it, which is most of us, but not all of us, we don't love it. We soft sell it, but the consensus or the seeming consensus, or not quite consensus, but feeling is that it's better than nothing. But as you point out, JFK, this is not meant to be forever, Jordi. It's until the next better thing comes along. So it's a bridge to the future. Now, PBM is even more controversial from the American standpoint, as the debate had happened, and that data, at least from that trial, is even softer than anything, at least has a smaller number and has more controversies, and light and laser have a risk factor as well. So they're all controversial right now. It just shows that this is a desperate patient population, and we'd like to do something for them. And right now, what we have is mediocre to less than mediocre. And at least in the American system, the GA treatment with complement inhibition is free, whereas PBM is probably less beneficial and is costing patients out of pocket $2,000 a session So you go from, in my mind, bad to worse, for what it's worth.
Thank you. So this is really the end. Maybe Anat, you want to come to close because this is the last one. Barrio, okay.
Walking is not a problem for Anat.
Well, thank you, everyone. Thank you for the moderators, for the speakers, for everybody. It was a great session. It was a great meeting. Thank you all for your attendance, your participation, your involvement. It's always a pleasure to do this with Anat. I'm the new kid on the block, but she keeps telling me I'm not. She's the one that's been doing it. I was the faculty for many years and now helped run it in the last few years, but it's you since the beginning. I was promoted, yes, but she's the boss as far as I'm concerned. So I'm here at her bidding, but it's great working with you, Anat, and it's great having you all. Thank you so much.
Thank you so much.
Yeah.
Stand in line, marking time, waiting for the welfare dime. Guess they can buy a job. The man the six at Harry's bias that catches a poor lady's eyes. Just for fun, he said.